So welcome to our part on the female reproductive system, right? But before we get into the nitty-gritty, I just want to give you an overview of what we'll be discussing, right? And yesterday we didn't have a chance to talk about the hormonal regulation of the male reproductive function, so I want to pick up there and then we'll move on to the female reproductive system. And we will talk about the various parts of the female reproductive system. We'll start with the ovaries, and then we'll discuss about the uterine tubes, the function of the uterus and the vagina, and finally we'll discuss some of the external genitalia as well. And among the accessory organs, I'll only talk about one accessory organ in the female reproductive tract, but the mammary glands is the second accessory gland we'll be considering. And then we'll talk about the various steps involved in oogenesis, and again we'll see that mitosis and meiosis will play a pretty important role, and you can see that there are some key differences. In spermatogenesis, the outcome of meiosis 2 will be 4 sperm. Here you only have 1 egg. What is the reason for that? We'll talk about that. And finally we'll wrap up by talking about the hormonal regulation of the female reproductive function. And I'm not sure if we'll get to this, but if time doesn't permit, we'll talk about contraception and STDs next week. All right. So with that, I will silence my phone and we'll get started. All right. So I just want to bring your attention back to this slide. So I told you that the hypothalamus can release a number of hormones which will in turn have an impact on the anterior pituitary gland, and that can release more hormones. But our focus today will mainly be on the FSH and the LH, which is released by the anterior lobe of the pituitary gland. So just to remind you, FSH stands for the follicle stimulating hormone, and this name makes more sense when we consider the ovary. There are no follicles in the testes, but this name is carried over from there. But we'll see what its function is, and then we'll talk about the function of the luteinizing hormone as well. So this picture here is a cross section of the seminiferous tubules, and what we discuss is mainly going to happen in the seminiferous tubule, right? So my goal of showing you this picture is to tell you where it is happening, whereas the panel on the right we will see what is actually happening. So this slide here is really important, and I want you to know what the various steps are, and I would highly recommend that you can draw this out from memory. And just notice that there are two types of lines. We have the red lines with the pointy arrow at the end, which is indicating stimulation, and if it's a blue line with the minus sign at the end of it, it's indicating inhibition. So our story is going to start with the hypothalamus releasing the GnRH hormone. So this stands for the gonadotropin releasing hormone, and this will be produced at the beginning of puberty, right? So until then males don't produce GnRH, and GnRH, its levels is going to remain steady throughout the reproductive life of the male. So there will be an increase and then it will decrease, and I'll tell you what causes its upregulation and also inhibition. But this GnRH is going to act on the anterior lobe of the pituitary gland, and it causes two other hormones to be released. The first one is FSH and the second is LH, or the luteinizing hormone. So let's first consider what the luteinizing hormone does. So the luteinizing hormone, it's going to act on the testes, and specifically it's going to act on the interstitial endocrine cells. So the alternate name for this is also known as Leydig cells. You're welcome to use either term. So it acts on these Leydig cells, and it will cause it to produce testosterone. Notice that there is one arrow pointing towards the testes, meaning that testosterone will have an impact on the testes, and we will consider that in a minute. But first, notice that it has some peripheral effects on various parts of the body. So let's consider what these 4 peripheral effects are. First and foremost, it's going to play a role in increasing bone and muscle growth. And that is the reason why you've even heard of maybe bodybuilders trying to take testosterone injections, and that can help increase the muscle mass and also just the overall physical size. But there's a downside to this, and the short answer is it can cause infertility, right? So by the end of this slide, you should be able to explain why having excessive levels of exogenous testosterone can lead to infertility. Secondly, we also see that it's going to help with the male secondary sex characteristics. So this could include deepening of the voice, or maybe hair growing in various parts of the body. And this also helps to maintain the accessory glands like the seminal vesicles, the prostate gland, bulbourethral gland, and the related organs. And finally, testosterone also helps to maintain libido, which is in other terms just called as the sex drive as well. So these are some of the peripheral effects of testosterone. But now we'll consider what testosterone does in the testes specifically. And to understand that, we need to go back and see what is the function of the follicle stimulating hormone. So there are other cells in the pituitary gland which will release the FSH, or the follicle stimulating hormone. So FSH, it's also going to act on the testes, but notice that it will act on a different type of cells, the nurse cells. So the nurse cells are the really large cells which extend all the way from the basal compartment down to the lumen. And there are three things which are going to be secreted by these nurse cells. So the first one is inhibin. Secondly, it's the androgen binding protein, abbreviated as ABP. And thirdly, it can also help to promote spermatogenesis. So we're going to first consider what this androgen binding protein does, and then how it can play a role in promoting spermatogenesis, and then we'll talk about inhibin. So notice that the testosterone which is being produced by the endocrine cells in the seminiferous tubules, they will be bound by ABP, right? So this androgen binding protein will bind to testosterone, and that will increase the concentration of testosterone in the testes by around 20 to 200 fold, right? So it's going to greatly increase the testosterone concentration, and thereby testosterone can help with the spermatid maturation. You remember that spermatids are what is produced at the end of meiosis II, but it doesn't look like a sperm, and so it has to undergo physical changes before it starts looking like a sperm, and those steps are called spermiogenesis, and that's what testosterone is going to help in. We also see that the FSH acting on the nerve cells, right, is going to help provide an environment which will promote spermatogenesis. So it's going to help promote both mitosis, meiosis, and then once meiosis II is over, testosterone can also help in the sperm to physically mature. So that's what we see happens in the nerve cells as far as ABP and in promoting spermatogenesis. Now notice that inhibin, as the name indicates, it's going to inhibit something, and it has a negative feedback effect. So we see inhibin is going to have a negative feedback effect on the follicle stimulating hormone, and it is also thought that it can have a negative feedback effect on GnRH release as well. And you may be wondering, why is this blue line dotted and there's a question mark here? There are still some questions regarding the role of inhibin in having a feedback effect on GnRH release, but for the sake of our discussion, we'll consider that GnRH and FSH will be inhibited by the inhibin release. So we find that inhibin depresses GnRH and FSH production. And it's found that the more testosterone is going to be produced, leading to more sperm production, there will be more inhibin produced. So more sperm production, more inhibin is produced. That will have a negative feedback effect. Now it is not just inhibin which has a negative feedback effect, but even testosterone itself will have a feedback effect on GnRH release. So we see that as the testosterone levels are increasing, it's going to decrease the GnRH levels. If GnRH levels are decreased, both FSH and LH levels will be decreased, and as a result, the testosterone levels will be restored back to normal. Right, so that's how the level of testosterone is going to be maintained in the male body. Are we clear on this? Is any aspect requiring clarification? GnRH causes two hormones to be released, and that will in turn act on the testes, and the testes will produce hormones which will act back on GnRH and then decrease GnRH release and FSH release as well. So we see that if a person were to take exogenous injection of testosterone, that's going to have a feedback, a negative feedback effect on GnRH release. And if you affect GnRH release, you're going to affect FSH and LH release. And without FSH and LH, you will not have the nerve cells being activated, right? And if the nerve cells aren't activated, then you cannot have the androgen binding protein being released. You will not have spermatogenesis being promoted, and that is why taking these exogenous testosterone injections can lead to male infertility. Is that clear, folks? Any clarifications at all? Okay. In that case, we can move on to the female reproductive system, and we will be revisiting how the female reproductive function is also controlled by various hormones, and that tends to be a little more complex than this, but it will build upon the concepts we have discussed here. So we see that even in the female reproductive system, we can divide the various structures into 4 categories. So there will be the gonads, which produce gametes and hormones, and in this case it would be the ovaries. And then there will be ducts, which can both receive and transport gametes, and the ducts which we consider here may not look like typical ducts, right? We have the uterine tubes, but even the uterus and the vagina will also be fall under the duct classification. And then there will be the accessory glands, which secrete fluids into these ducts. We'll look at one example of that. And finally, we'll consider a few parts of the external genitalia. So we see that the ovaries, they are the gonads which are going to produce oocytes, which is the female gamete, and it will produce hormones. And we'll see how these hormones can help to maintain the pregnancy. And we find that once the oocytes are going to be released from the ovary, they can move into the fallopian tube, also known as the uterine tubes, and it will move down this fallopian tube, and it can eventually reach the uterus. And the uterus is going to enclose and support the developing embryo, and if there is no embryo to support, then we see that the inner lining of the uterus will be lost in the monthly menstrual flow. Notice that the inferior part of the uterus is called the cervix, and this is usually pretty tight, but during sexual intercourse it will loosen slightly so that it can permit the sperm to go in. And generally speaking, the cervix will be having a consistency of your nose, right? That's how tough it will be, but then just before delivery it will get as loose as your lips, so that's how the cervix nature will change. And the cervix gives rise to the vagina, which connects the uterus to the exterior environment and the external genitalia as well. So just anterior to the vagina, you find that there is a clitoris. This is part of the external genitalia, and it will have the same embryonic origin as the penis in males. And immediately superior to the clitoris, you have the urinary bladder, and above that we have the uterus. And because of the positioning of the uterus right above the urinary bladder, as the pregnancy progresses, we see that the uterus will put pressure on the urinary bladder, and that's why pregnant women often feel the need to urinate. And notice that the urethral opening is going to be pretty close to the vagina, and that's one of the reasons for the increased risk of urinary tract infections. And the rectum is immediately posterior to the uterus, and the anus or the is shown inferior to the rectal passageway. And notice that the structure here is called the labium minus because that is the singular term, but if you consider the plural term, it's the labium minora, which will give rise to the labium majora, and labium majus is just the singular term. And these are the structures we will be considering in the upcoming slides, and this can be an overview of what are the various structures and what their functions are is what you'll be required to know. So we will come back to the structure of the ovary when we discuss how oogenesis takes place, but we will start our discussion with the structure of the uterine tubes. So here is the cross section of the fallopian or the uterine tubes, and if you take a closer look at the histological section, you'll notice that there's a lot of ciliated columnar epithelia, right, with two other types of cells. You have this mucin secreting cells and PEG cells as well. So this picture down below is actually a scanning electron micrograph, and you can only see two types of cells here. And you see this mucin secreting cells with the microvilli, and you also see the ciliated columnar epithelial cells. You see all of their cilia here. What you don't see in this panel down below is the PEG cells, right? But the PEG cells have a pretty important function, and these PEG cells, they are going to secrete a fluid which will help the sperm capacitation to be completed, right? And let me just remind you what capacitation is. So I told you that when the sperm is maturing in the epididymis, it is not capable of fertilizing the egg because there are two things which need to happen to it. Firstly, it needs to become motile, and it becomes motile when it's exposed to the seminal fluid. Secondly, I told you it can fertilize the egg only when it has been exposed to the female reproductive tract. And I'll tell you what is so unique about the female reproductive tract, and this is what it is, right? The fluid released by the PEG cells, which will help the sperm to be fully capacitated, and it can fertilize the egg. Notice that these cells can also provide nutrients for the sperm and for the pre-embryo. So the term pre-embryo is referring to the embryo for the first 2 weeks. After week 3 onwards, it gets the term embryo, and then from 3 to 8 weeks, it's the embryo, and then from week 9 onwards, it's referred to as the fetus. So we find that this cilia is going to move back and forth, and the uterine tubes will have peristaltic contractions, which will help propel the oocyte towards the uterus. And we already talked about how there's prostaglandins in the seminal fluid, which can help with in causing the male and the female reproductive tract to contract rhythmically. And these uterine tubes will provide an environment which can help the nourishment of both the sperm and the oocytes as well. So it's pretty straightforward what the uterine tubes do. They not only help in the passage of the sperm and the oocytes, but it also helps to nourish both the sperm and the oocyte. So now we can move on from the uterine tubes down to the uterus, and this uterus is a muscular organ. It serves a function to both protect the fetus, to nourish it, and it can also help to remove the wastes which are produced by the fetus. And notice here that the term embryo is used between the term 1 to 8 weeks. Specifically between 1 to 2 weeks, it's called proembryo. 3 to 8 weeks, it's called embryo, and after week 9 onwards, it's called the fetus until delivery. Now the inferior part of the uterus is called the cervix, and this is what will separate the vagina from the uterus. And now let's talk about the various membranes or various layers of the uterus. So we find that the uterine wall will have 3 specific layers. The innermost layer is called the endometrium. This is a glandular and a vascular layer, and the purpose of the glandular secretions and the vascularity is so that the physiological demands of the fetus can be met, right? So that is the purpose of the endometrium. And keep in mind that the thickness of the endometrium is very responsive to estrogen, and that is why as the levels of estrogen changes during the monthly menstrual cycle, the thickening of the endometrial wall will vary as well. So from there we move on to the middle layer, that is the myometrium. This is a muscular layer made up of smooth muscles, and notice that the smooth muscles are going to be arranged in different layers. So there will be a layer in which they are arranged in a longitudinal fashion, or another layer where they are arranged in a circular fashion, or also in an oblique or in a diagonal pattern. That's how the smooth muscles are arranged. And this type of arrangement means that pressure can be applied from all sides as the uterus contracts and relaxes. And so this contraction and relaxation can serve a number of functions. It can help to move the fetus out during delivery. Also during the monthly menstrual cycle, it can help to force out the menstrual flow. And even after intercourse, we see that the uterus muscles can contract and relax, and that can help to in the movement of the sperm as well. And finally, the outermost layer is called the perimetrium, and this will actually be continuous with the peritoneal lining. So I briefly talked about the peritoneum when we talked about the urinary system and how the kidneys are held behind the peritoneum, and they are said to be retroperitoneal, whereas the perimetrium is going to be continuous with the peritoneal lining. Yes? Yes, it is the myometrium which contracts and relaxes. Okay, so now we can move on from the uterus down to the vagina. And notice that even the vagina is a muscular tube. It's highly distensible, and it's going to extend all the way from the cervix down to this region known as the vestibule, and the vestibule will lead to the external genitalia. Notice that the vaginal canal is going to serve as a passageway for the elimination of both the menstrual fluids, and it is the canal which receives the penis during sexual intercourse. And this will form the inferior portion of the birth canal as well. So I want to draw your attention to two glands. So notice there's this gland here known as the greater vestibular gland. It's found on either side of the vestibule. And the reason I point out this gland is that it has the same embryonic origin as the bulbourethral gland. So I mentioned three accessory glands in the male reproductive system. You have the seminal vesicles, followed by the prostate gland and the bulbourethral gland, and it is the bulbourethral gland which will produce an alkaline mucus during arousal, and even in females this greater vestibular gland will secrete this mucus secretion during the arousal. So with that we can move to consider the external genitalia, and there are three things I want to discuss in the external genitalia. The first is the clitoris, and we see that this is made up of erectile tissue. It has the same embryonic origin as the penis in males. And the reason I point out the clitoris is when we talked about the sex determinants, we will see how the clitoris forms versus the penis forms. And then immediately posterior to the clitoris, there is this area known as the labia minora. These are small folds which are found around the vestibule, and the key thing to note here is it's got hairless skin. And surrounding the labia minora, there's the labia majora, where there are more prominent folds of skin and adipose tissue, and this is covered with coarse hair, right? So these are the few things I would point out as far as the external genitalia is concerned. And now let's move on to the second type of accessory gland I will mention, and this is the mammary glands. So the key thing to remember with mammary glands is that it is a part of the integumentary system. We see that it plays an important role in the reproductive function because it can help in producing milk which nourishes the infant, but we find that it's a part of the integumentary system. So this is a good thing we can ask for multiple choice questions. Which system does this fit into? So we find that the mammary glands is made up of a number of lobes, as you see here. Here are multiple lobes, and each of these lobes, they are made up of small lobules. So these lobules looks like grapes in a cluster, and the lobe is like a grape cluster. And each of these lobules, they are going to give rise to what is known as a mammary gland duct. The mammary gland duct isn't marked on this picture, but it will be here, and all of these mammary gland ducts will join together to form a lactiferous duct. So there are multiple lactiferous ducts shown here, and all of these lactiferous ducts, they will give rise to a lactiferous sinus, and this lactiferous sinus will join to lead to the opening of the mammary gland, which is found under the nipple. And notice that that each of these lobes of the mammary glands, they're going to be separated from one another by dense connective tissue, and you can even see that this connective tissue will eventually connect the mammary glands to the muscle underlying in the chest. So this is the pectoralis muscle. Notice also the nipple is surrounded by a darker colored skin called the areola, and we find that as pregnancy progresses, the areola will become more darker in color because of melanin pigment production. We talked about melanocyte stimulating hormone MSH in the endocrine system, and that can help the infant to see the nipple more easily and to latch on with greater ease as well. And so this is something we'll consider when we talk about changes in the body as the pregnancy progresses. Okay, so now we can finally move to talk about the ovaries, right? So in the ovaries, I want to point out the structure called the ovarian follicles. So these are specialized structures surrounding the oocyte, where the oocyte can both grow and mature. So there are different types of follicles depending on the developmental stage of the oocyte inside it. So firstly, we have the primordial follicles, and the primordial follicle contains the primary oocytes, and it is surrounded by a single layer of squamous follicular cells. And we find that these primordial follicles will eventually develop and form a primordial ovarian follicle. So the difference between the primordial and the primary follicle is that the primary follicle will have simple cuboidal epithelium around it. So it's no longer squamous, but it's going to be simple cuboidal epithelium. And this primary follicle will in turn give rise to a secondary follicle as shown here. And the key difference between the primary and the secondary follicle is that the number of cells which are surrounding the primary oocyte, right? So we find that there will be stratified cuboidal epithelium. There will be multiple layers of cuboidal cells surrounding the primary oocyte. And this secondary follicle will give rise to the tertiary ovarian follicle. And the key difference is that the tertiary ovarian follicle has got this follicular fluid, and we find that it is going to contain the secondary oocyte, right? And so until this point of the secondary ovarian follicle, it would be the primary oocyte, but then in the tertiary ovarian follicle, it will be the secondary oocyte. And we find that this follicle will eventually rupture during ovulation, and this secondary oocyte will be released, and this follicle will turn into a corpus luteum, a structure which produces progesterone, and eventually it can degrade and form the structure called the corpus albicans. So we will talk about how these various steps in the ovarian cycle take place, but first I need to remind you again of what happens during mitosis and meiosis. So this is a slide which we walked through step by step yesterday, but today let me just briefly tell you the overarching themes. We see that in mitosis you have fewer steps, and the end goal is you will have two identical daughter cells, whereas in meiosis you're going to have more steps, so you will end up with more daughter cells, and also in the very first step there will be some crossing over of genetic material, and that is why the cells which are formed at the end are all unique, right? So in spermatogenesis things go exactly as explained in this slide. So you start with one primary spermatocyte and you end up with 4 spermatids. Whereas in oogenesis, we find that you could end up with only one egg at the end of oogenesis, and we'll see what is the reason for that. So we find that at the beginning of meiosis, we'll have all the genetic material being duplicated, and now you have 4 copies of chromosomes at the beginning of meiosis 1. But by the end of meiosis 1, we see half the genetic material will be lost in a first polar body, and then by the time meiosis 2 takes place, we see another half of the genetic material is lost, and you end up with only 1 copy of the genetic material, and so you end up with only 1 oocyte at the end of oogenesis. So let's talk about the various steps which take place here. So we find that the ogonium, or the stem cell which leads to formation of the egg, is going to undergo mitosis, and you have 2 primary oocytes being formed. Now the key thing to remember is that in females, this mitosis is going to take place in the fetus, and it's going to happen during the first couple of months during the fetal development, right? And then by the time you reach around the 3rd to 7th month, we see that only some of these primary oocytes are going to undergo meiosis 1. And so in meiosis 1, the very first step is prophase 1, and during prophase we'll have the DNA being replicated, and at that point meiosis 1 will halt, right? And we find that before birth, between 3rd to 7th month, we see meiosis 1 is going to halt in prophase 1, and it's not going to resume until puberty. So during puberty, we have the follicle stimulating hormone which will come, and it will cause meiosis 1 to resume, and by the time meiosis 1 completes, half the genetic material is lost in a first polar body, right? And we have only 1 secondary oocyte being produced at the end of meiosis 1. And then we find that the secondary oocyte is what is going to be released during ovulation, and we find that the remaining the next half is also lost as a secondary polar body, and we find that meiosis 2 will only complete during fertilization, and this is something we'll revisit when we talk about fertilization next week, right? We'll talk about these details, but for now let me just point out that during the first few months of fetal development, because mitosis takes place, you have around 7 million oocytes, right? And then there's a process called atresia, through which most of these oocytes are lost, and by birth, by the time the baby is born, there are only 1 to 2 million oocytes. And by puberty, we see that the number of oocytes have again continued to decrease, and you have around 50,000 oocytes, and in an adult around 300,000 oocytes, and eventually when all these oocytes die off, that's when menopause will set in. So now let's talk about the various steps involved in the endocrine regulation of the female reproductive function. So notice that again in this slide we are mainly going to focus on the function of the follicle stimulating hormone and the luteinizing hormone. But keep in mind that the follicle stimulating hormone and the luteinizing hormone, they are going to have an impact on the uterus and also on the ovaries as well. So there will be a uterine cycle and an ovarian cycle we'll be considering, right? So we find that the ovarian and the uterine cycles must operate in synchrony to ensure proper reproductive function in females. So this will start with the GnRH hormone being released during puberty, and unlike in males where the GnRH is going to cause the production and the release of FSH and LH, there's something slightly different happening in females. So notice that as far as FSH production and secretion are concerned, that is controlled by GnRH, right? Whereas when it comes to the luteinizing hormone, its production is going to be mediated by GnRH, but the secretion of the luteinizing hormone will be mediated by something else, right? And the short answer is estrogen will help in the release of the luteinizing hormone. So let's see what happens as a result of FSH and LH as well. So FSH is going to act on the ovaries to help with the follicle development. So we previously talked about how the primordial follicles are going to give rise to the primary follicle, secondary follicle, tertiary follicle. All that is possible because of the follicle stimulating hormone. So the name explains exactly what it is going to do. We also find that FSH leads to the release of inhibin, as we saw in the testes, and it's also going to help in the formation of estrogen as well. So estrogen has got a number of peripheral effects, like how testosterone has peripheral effects in males, and we see that it can impact the central nervous system function as well, right? And it can also play a role in the development of secondary sex characteristics, like the deposition of fat on the hips, the breast development, and we find that estrogen can also help in bone and muscle growth. And this is something you are all familiar with. We talked about osteoporosis risk increasing when there is a drop in estrogen levels. So we find that estrogen is important for both bone and muscle growth. We also see that the accessory glands and the respective organ development can also be influenced by estrogen. And finally, estrogen will also help with stimulating the endometrial lining and the respective secretions as well. So estrogen has all of these peripheral effects. Now notice that estrogen can also play a role in this follicular phase, right? So follicular phase is where you have all of these follicles being developed, and as far as the follicle phase is concerned, notice that the FSH level is going to slightly drop because inhibin is also being produced by the FSH cells, and inhibin will have a negative feedback on the FSH release, just like how we considered in the male reproductive system. And we find that the release of LH, or the luteinizing hormone, is going to be mediated by estrogen. So I want to draw your attention to these two ovals here, right? So we find that before until 10 days, we find that estrogen levels aren't high enough, and so estrogen will actually inhibit the release of the luteinizing hormone. But after day 14, as shown right here, the estrogen levels are high enough, and that's when the luteinizing hormone can be released. And this makes sense because you want the luteinizing hormone to be released only when the follicle has developed, right? And so the luteinizing hormone is going to act on the follicles and cause them to ovulate, meaning the follicle will rupture and the oocyte will be released. We also see that the luteinizing hormone is going to cause this follicle to develop into the corpus luteum, and the corpus luteum is what will produce the hormone progesterone. And progesterone has a number of effects, right? So progesterone is going to have a negative feedback effect, and it will inhibit the release of GnRH. So if GnRH levels are decreased, then you will have less FSH and also LH being produced. And so I'll just give you a preview now that estrogen is going to be one of the main hormones which will be used in contraceptives, because if you have progesterone, it will prevent this ovulation, and so pregnancy cannot happen, right? So now let's use all the information I gave in this slide and see how the ovarian and the uterine cycles are affected. Are there any questions before we proceed at all? Okay, great. So this is a slide which is extremely important, right? If you this is kind of like the slide we looked at in the cardiac cycle, where you have the electrical activity, pressure changes, volume changes. This is similar to that. Notice that we are going to see changes in the hormones related to the hypothalamus and the pituitary gland in this first panel. The second panel, we see how in the ovary the various stages of follicles are developing with respect to time. And then in the third panel, we see what are the various ovarian hormones which are produced and how they change with respect to time. And the last panel, we see how the endometrial lining in the uterus is going to change with time as well. Right? I'm going to walk through this once. If anything isn't clear, please stop me. I'll walk you through this. But the one thing I want you to keep asking yourself is, what is causing this level to go up and come down? Just ask yourself that question for each and every one of these lines, right? So each of these lines indicate a different hormone, and be able to answer why something is going up and why it is coming down. So our story begins with the gonadotrophin releasing hormone. It's shown here in green, and notice that the GnRH level is gradually increasing, right? That's what we start our discussion with. This level starts increasing beginning with puberty. And GnRH is going to have an effect on the synthesis of two other hormones. We see that FSH is shown here in blue. We see the FSH levels increase as well. But this pink line here is indicating the luteinizing hormone, and notice that for most of the time the luteinizing hormone levels are being flat, right? And the reason for that is GnRH is producing both FSH and LH, but only FSH is being released. In order for the luteinizing hormone to be released, something else needs to come into play. And if you just look down here, this red line indicates estrogen, and when estrogen levels are high enough, that's when luteinizing hormone is released. Okay, now let's just come down to the lower panel, and we find that because of FSH levels increasing, the ovarian follicles are developing, right? And we notice that this entire phase is called the follicular phase because the follicles are developing. But once the follicle ovulates, it will lead into the luteal phase. So notice that because of FSH stimulation, the estrogen levels also gradually start increasing, and when the estrogen level reaches a certain limit, that's when there is this luteal surge, and the luteinizing hormone can cause the ovulation to take place. Now I also want you to notice that in the ovarian hormones you have estrogen released and also inhibin being released, and because inhibin is released, notice that the FSH levels slightly drop because inhibin is having a negative feedback effect. And we find that once ovulation takes place, we find that as a result of the luteinizing hormone levels being high, we find that the corpus luteum is being formed. And as the corpus luteum is formed, it's going to release progesterone, the hormone indicated by the black line, right? So progesterone will help to maintain the pregnancy, and if a woman is pregnant, eventually the placenta will start releasing the progesterone, but initially progesterone is what helps to maintain the pregnancy initially. And notice that as the progesterone levels are high, the GnRH levels are low because progesterone has a negative feedback effect on GnRH release, and when GnRH levels are low, you find that even the FSH and LH levels are low as well. Okay, and we find that the corpus luteum does not last forever. It's eventually going to degrade and form the corpus albicans, and we find that as the corpus luteum degrades, it can no longer produce progesterone. As progesterone levels drop, we find that the GnRH levels start increasing again, and that can trigger a new ovarian cycle. So up to this point, I've only talked to you about the first three panels. I completely ignored the uterine cycle, right? So notice that when you have no GnRH for a while and then you have GnRH being produced again, it leads to the menstrual phase. And notice that the estrogen levels, as they are increasing, we have the proliferative phase where the endometrial lining starts to grow and it is producing more secretions. And if in the secretory phase, if the fertilization takes place, then it can bind to the endometrial lining and the fetus can develop. So again, just to remind you, as long as progesterone levels are high, as in the case of contraceptives, you will not have this ovulation taking place, and that can prevent pregnancies. And secondly, estrogen can also have a negative feedback effect on FSH release. So let me just summarize what I said. As progesterone levels are high, it's going to decrease the GnRH secretion, and when there is no pregnancy, we find that the corpus luteum degenerates, it degrades, and that will decrease progesterone levels, which will trigger the menstrual cycle, and the GnRH levels go up again and a new cycle begins. So in menopause, right, we find that a time will come when menstrual cycles will cease, and we see that this is going to begin between the age 45 to 55 years for women, and we find that this is because there are no more primordial follicles, right, because they've all been lost. But we see that during menopause, the circulating levels of estrogen and progesterone will be low, but there will be a sharp increase in GnRH, FSH, and LH levels. And folks, this statement here is super important. If you want to put 3 asterisks next to it, because to explain the sentence, you need to understand what is happening in the ovaries. So we find that as women grow older, there is going to be a decline in the cells known as granulosa cells, which actually produce estrogen and inhibin as well. So let me just walk you through this figure. We find that in the ovaries, there are 2 types of cells, granulosa cells and these theca cells, and these theca cells will actually produce androgens, just like how the Leydig cells in the testes produce androgens, right? And we find that the androgens will be converted into estrogen by the granulosa cells. So as a woman gets older and she has fewer granulosa cells, the estrogen levels drop, right? And the inhibin levels drop. Now, without inhibin and estrogen to have a negative feedback effect on blocking both the GnRH, FSH, and the LH release, that is why the levels of GnRH, FSH, and LH are high, but progesterone and estrogen levels are low. Is this clear? This is a really important figure, and it may not be very intuitive, but keep in mind that you know the answer to why you have low levels of estrogen and progesterone. Okay, anyway, we find that as the levels of estrogen drop, it can lead to reduction in the breast size and also the size of the uterus. It can make the thinning of the vaginal and the urethral epithelia, which can increase the risk of urinary tract infection. And most importantly, we find that there's a reduction in the rate of bone deposition as well, because estrogen is needed for both bone and muscle growth as well. Okay, do you guys have a chance to copy this down? Okay, if so, we are going to jump straight to the summary slide, right? We will talk about contraceptives next week, right? So we find that we've been talking about the hormonal regulation of the male and the female reproductive system, and in the female reproductive system, we talked about how ovaries will produce hormones and oocytes. The uterine tubes will transport the oocyte to the uterus, and the uterus can protect and support the growth of the embryo. And we discussed how the mammary glands can provide nourishment for the infant. And we finally wrapped up by talking about the hormonal regulation of both the male and the female reproductive function by the hypothalamic, pituitary, and gonadal axis. All right. So thank you all, and have a great weekend. And we'll start next week